Our next speaker is Dr. Daniel Cohen. He is a radiologist at Hudson Valley Radiology Associates, and he's also a member of the Hackensack University Medical Center Fetal Care Team. Today he's going to be discussing with us the MRI of non-adherent placental disease and IUGR.
Good afternoon. So today's case presentations are also going to be examples of cases referred to me by MFMs where the MR study and the post-MR targeted ultrasound revealed diseases that were unsuspected based on the referral clinical indication. And the first case that I'm going to discuss is that of profound bilateral cerebral encephalomalacia in association with a true cord knot and abnormal placental histopathology. And the patient was referred to me at 39 weeks. The baby was a little small, about 13%, and the MFM had identified new fluid spaces, new intracranial fluid spaces, and wanted a fetal brain MR to look for that, to look at more detail. The abdominal circumference was about 3.5 weeks smaller than expected. The MR of the fetus showed severe bilateral cerebral non-hemorrhagic ischemic insults, sparing only small portions of the brain. Because we're imaging the brain and we're seeing the head and neck region, the MR demonstrated a true umbilical cord knot, and the placenta showed profound abnormality. The pregnancy outcome at 1 year of age, this was an institutionalized infant that was deaf, blind, and paralyzed. The placental pathology showed a hypercoiled umbilical cord and compromised fetal circulation, multifocal segmental avascular villi. I lost my laser pointer. Could you bring my laser pointer back? Okay, thank you. Could we dim the lights a little bit? Thank you. So this quite sad case, this is a brain MR, and this is a T1 sequence, and the only portion of the brain that's normal are these paramedian segments of the occipital lobes. All of the remainder of the cerebral hemispheres show gross ischemic insult. And so we had a lot to work with on the MR, and this is what's called a vascular flow study, and this is actually the brain, and this is the neck region right here, and this is the non-knotted portion of the umbilical cord, and this is a true cord knot here on a diffusion, and then in another, looking at it in another orthogonal plane of section, you can see this. This is the cord knot right here. Now, so we had profound cerebral disease. We have a true cord knot. We have a baby that's at the 13th percentile. What about the placenta? And this, again, this is a diffusion-weighted sequence, and we see a very abnormal placenta with multiple strands of multiple dark, thick strands. Again, a repetitive thought is that normal umbilical artery Doppler can be falsely reassuring. This is a true cord knot with a normal umbilical cord tracing. I show these slides because I'm a firm believer that MR and high-quality ultrasound go hand in hand. Excuse me. And this is a transfontanelle ultrasound of the brain showing periventricular cystic encephalomalacia. So what are the teaching points from this case? The association between late onset SGA, profound brain abnormality, and placental and umbilical cord disease in the context of normal umbilical artery Doppler. The MR identification of brain disease necessitated change in site of delivery. This was a patient that was originally intended to deliver at a community hospital. The complementary attributes of MR and transfontanelle neurosonography, and the comorbid pathoclinical association between umbilical cord dysmorphology, and I would include in that marginal and velamentous cords, complete and partial circumvalid placentation, periplacental subchorionic hematomas, which are the consequence of low pressure, usually clinically silent venous abruptions, and fetal brain disease. Umbilical cord knots in patients requiring emergency C-sections for non-reassuring fetal heart tracings are found to have a statistically significant increased incidence, almost 20%, of placental lesions related to maternal vascular supply and fetal thromboocclusive disease in comparison to those that were able to deliver vaginally. So umbilical cord disease and placental disease that can have clinical consequences are a known association. We had covered a lot of this in my previous talk, but why consider placental MR for unexplained early growth restriction is because there are major placental histopathologies that have increased recurrence risk in future pregnancies that are associated with adverse placenta-related obstetrical outcomes and are associated with stillbirth and cerebral palsy. Next case is a 30-week pregnancy that resulted in a C-section, and the final pathology report was uteroplacental malperfusion. But the reason for the MR referral was an abnormal fetal brain, a question of an abnormal fetal brain on ultrasound. The MFM reported no placental abnormalities. The fetus was 5 weeks smaller than dates. The mom had positive anti-cardiolipin antibodies, had multiple extremely abnormal biochemical analytes, and a past history of IUGR and preeclampsia. But the reason for the MR referral was to look at the brain. Again, this is a normal placenta on ultrasound. And what did the MR of the brain show that was not seen on the MFM ultrasound? And that is intraventricular bleed. This is hemosiderin deposition within the anterior horn of one of the lateral ventricles. And these are periventricular germinal matrix brain insults. And how did the placenta look? We see again this very heterogeneous placental mixture of signal intensities, dark, gray, white. We see no macromorphologic placental bleeds. The diffusion-weighted sequence, again, shows this big, blotchy, dark area within the placenta. So this is evidence of significant dysfunctional placental tissue. This is a case where the patient presented to us with normal umbilical arterial Dopplers, and we, in this case, did umbilical venous Dopplers and quantitative umbilical venous Dopplers and the quantitative flow at 62 milliliters per minute per kilogram was less than the 2.5th percentile for gestational age, with preservation of diastolic umbilical arterial flow. Pregnancy outcome, there was a C-section 1 day after the MR when the umbilical arterial Doppler diastolic flow became absent. Birth weight was 1.5 pounds, critically ill, severe pulmonary hypertension, normal genetics in microarray. The placental pathology, as expected, a small 145-gram placenta with marked increased syncytial knots, increased perivillous fibrin, multiple villus infarcts occupying about 15%. So I think the teaching points of this case are several. The MR was able to diagnose placental and fetal disease not seen on MFM referral ultrasound. And this occurred in the preservation of diastolic umbilical arterial flow. The detection of significant decreased quantitative umbilical venous flow substantiates as dysfunctional the abnormal appearing of the placenta. And again, the multiplicity of extreme biochemical analytes confers increased risk for placental dysfunction. Next case is that of amniotic twins with twin A death due to an abdominal arterial venous fistula and large hemorrhagic placental infarct. The MFM, the reason for referral was SGA in twin A with prominent intracranial ventricles. So again, the MR referral was for rule out brain disease. With normal Dopplers, there was no MFM reporting of placental abnormalities. The MR showed normal brain, and the MR of the placenta showed a large placental infarct. My targeted ultrasound after the MR showed echogenic bowel, and whenever I have placental disease, small baby, echogenic bowel, I look for abnormal arterial venous fistulas in the fetus that can cause mesenteric ischemia and be a cause for SGA and echogenic bowel. Let's go on to the imaging findings here. So this is the small twin A with mild diminution in fluid around twin A. And here, this is with twins, this is twin B's placenta, which is normal. Twin A's placenta has this large hemorrhagic infarct. And that's, so MR is able, with twins, to look at differences between each placenta. Again, another example of a large hemorrhagic placental infarct on T2. On T1, it's white. T1 is, if you're looking for infarcts anywhere in the placenta or the fetus, you have to do a T1 sequence. If you are ordering MRs and in the technique section of the MR report, if they don't say that they've done a T1 sequence, it really is not a complete study. This is aorta. This is an enlarged celiac artery, fistulizing within the liver, echogenic bowel right here. This is the Doppler tracing of that arterial venous fistula. And we have systolic pulsations in the umbilical vein. So the presence of this arterial venous fistula within the liver steals blood from the intestines, causing the intestines to be echogenic and producing acidosis, creating metabolic acidosis within the fetus. An example of the quantitative umbilical venous Doppler. This is the good twin B's umbilical vein, normal size. The diameter is about almost 3 millimeters. The quantitative flow was 94 milliliters per minute. This is twin A's small umbilical vein. The area here is 0.05 centimeters squared, and its flow was 18 milliliters per minute. So again, this helped substantiate that what we saw in terms of the placenta actually had functional consequence in terms of the amount of blood that that umbilical vein was carrying. So the teaching points here were that, again, MR can diagnose placental disease not seen on ultrasound. MR has a superior sensitivity in detecting hemorrhagic and non-hemorrhagic alterations in placental pathology. Hemorrhagic placental infarcts carry significantly higher risk. Echogenic bowel, don't forget, is a differential possibility. Abdominal arterial venous fistulas are under-recognized and represent bowel ischemia and are a source of acidosis. The MR diagnosis of placental disease in the SGA fetus necessitates search for fetal end organ disease. Again, the end organ disease in this case was the intestines. The end organ disease in the prior case was the brain. And I think my last case here will be, again, this was a monodi pregnancy, discordant for estimated fetal weight, discordant for placental disease. This ended up with a C-section at 30 weeks. The reason for the MFM referral was rule out fetal malformation to account for the discordant weight. The estimated fetal weight for twin B was at the 17th percentile and twin A at the 40th percentile. There were normal twin umbilical, arterial, and middle cerebral artery Dopplers. There was no MFM reporting of placental abnormality. Ultimately, I'm going to be showing you images that show twin B, the smaller twin, to have microcolon and meconium ileus and microcolon. There was no cystic fibrosis. Twin B's placenta was diffusely abnormal. As I mentioned, the birth weights at 30 weeks for the smaller twin was 1,200 grams and the larger twin 1,800 grams. So in addition to MR identifies meconium in the colon beautifully. And it's a great tool whenever you are looking for fetal bowel disease. You want to know, is it small bowel or large bowel? And by 20 weeks, more than 90% of normal fetuses will have meconium in the rectum. And you can trace it all the way to the anus. So this is the twin B. This is twin A, the good twin, and this is a T1 sequence. And on T1, meconium is white. It looks like just a toothpaste sign. This is the bladder right here. So this is rectal meconium going all the way down to the anal region. And on twin B, we don't see that. So there's no rectal meconium. And the differential for that is anal rectal atresia, a high anal rectal atresia, Hirschsprung's disease, or as in this case, meconium ileus. Now, it is abnormal to see meconium in the small bowel. And in this affected fetus, twin B, because of the ileus and the increased, because of the meconium ileus, we have this same appearance of meconium in the small bowel. So you should never see at 20 weeks meconium in the small bowel. And so this is a sort of a unique contribution of MR, I believe. In terms of placental disease, Again, this is twin B's placenta, dark, normal twin A's placenta, same dark diseased placenta here, normal placenta here. Again, we are seeking evidence. We want to use all the tools in our toolbox to substantiate placental dysfunction, and here we have a side-by-side comparison of normal twin B's umbilical vein, 1.08 square centimeters with a quantitative umbilical venous flow of 677 milliliters per minute. This is small twin A. The umbilical vein area is 0.36 with 142 milliliters per minute. So significant difference in umbilical venous flow. So what are the teaching points here? MFM ultrasound identified discordant estimated fetal weight of an uncertain etiology, no fetal malformation, and normal umbilical arterial and middle cerebral artery Dopplers, and no ultrasound visible placental abnormality. Fetal MR, placental MR, and quantitative umbilical venous Doppler identified not only discordant placental disease, but also diagnosed ischemic end organ disease manifested by meconium ileus and microcolon in the small twin. Fetal intestinal ischemia is considered a significant etiologic factor for meconium ileus in the premature IUGR fetus, resulting in neonatal meconium intestinal obstruction. So I'd like to just summarize the key points from these case studies. MR can detect placental and fetal end organ disease that is occult on ultrasound and umbilical artery Doppler. Consider fetal and placental MR for your IUGR pregnancies, especially when Dopplers are negative. And when you have IUGR, MR can detect fetal end organ disease, brain, kidneys, intestines that are not seen on ultrasound. And lastly, MR detection of placental and/or fetal abnormalities establishes antecedent disease mitigating against obstetrical management causation. Thank you.